My name is Dr. Nathan Stahl, and I'm a geriatrician at Sinai Health in Toronto, Ontario, and a research fellow at the University of Toronto. I'm going to be presenting an evidence brief on COVID-19 and Ontario's long-term care homes as part of the Ontario COVID-19 Science Advisory Table. We know that COVID-19 has taken a substantial toll on Ontario's long-term care homes. As of December 12, 2020, we've had nearly 2,500 resident deaths, 8 long-term care worker deaths, and the resident deaths in our province have accounted for 63% of all of Ontario's COVID-19 fatalities. The second wave is accelerating within long-term care homes. The second wave began on September 1st, 2020, and 69% of resident cases during the second wave alone have occurred between November 1st and December 12th, and 80% of resident deaths have occurred during that same time period, really reflecting and highlighting the recent intensification of the pandemic within the sector in the recent weeks. To reduce COVID-19 morbidity, mortality, and hospitalizations, strong action is needed to improve the prevention and mitigation of COVID-19 outbreaks in long-term care homes. The key messages of this science table brief are that Ontario long-term care residents have experienced disproportionately high morbidity and mortality, both from SARS-CoV-2 infection, the causative infectious agent of COVID-19, and also from the conditions of the COVID-19 pandemic, with many residents suffering harm and even death, not from the infection itself, but from the conditions they were living under during the pandemic. When we compare waves 1, which takes us until August 31st, 2020, and wave 2, which starts on September 1st, 2020 and is ongoing, there are some improvements in some indicators. However, as mentioned, the second wave is intensifying in the long-term care sector, and without action, we're going to see and continue to see substantial loss of life before the arrival, distribution, and administration of a vaccine at a widespread level. A lot of evidence has accumulated to document the predictors of long-term care home outbreak spread of infection and deaths, and these remain unchanged during the second wave. Some of the evidence, as you'll see, on COVID-19 in Ontario long-term care homes has been effectively leveraged to support public health interventions and policies. But there are a number of outstanding issues in the sector, and several measures are proposed which have the potential to both prevent COVID-19 outbreaks in long-term care homes and prevent deaths of residents and staff. As an overview of Ontario's long-term care sector, Ontario has 623 licensed long-term care homes and nearly 80,000 long-stay beds. 58% of the province's homes are for-profit, 24% are non-profit or charitable, and 16% are run by the municipalities. About 300 homes are older and need to be redeveloped, which accounts for nearly 30,000 beds. Ontario long-term care residents receive personal and nursing care, as well as subsidized accommodation under a publicly funded long-term care program. And as of February 2019, there were nearly 35,000 individuals on the long-term care waitlist who waited an average of 161 days for placement. Residents who live in long-term care are complex. They are medically complex. 90% of residents have some form of cognitive impairment, 70% live with a diagnosis of dementia, and 86% need extensive help with basic activities of daily living, such as dressing, grooming, or bathing. What we've seen over the last couple decades is an increasing complexity of newly admitted long-term care residents, which are increasingly older, increasingly have more comorbid or multiple medical conditions, take on average more medications, and have more advanced forms of functional impairment and cognitive impairment. And these individuals require substantial support to live within Ontario's long-term care homes. This is a graph showing long-term care home outbreaks involving resident cases in waves 1 and waves 2. Wave 1, as mentioned, goes until August 31st, 2020, and wave 2 starts on September 1st, 2020 and is ongoing. Nearly 6,000 residents were infected during wave 1, with 1,910 resident deaths and 8 staff deaths. During wave 2, starting on September 1st, and as of December 12th, when the data was extracted, there have been 3,304 resident cases and 543 resident deaths. You'll note that there is a slower rate of outbreaks in the long-term care homes during wave 2, and also there are less homes under outbreak that involve resident cases. Additionally, the color gradient displayed towards the red end of the spectrum, displaying more residents infected per outbreak, shows that there have been less large and widespread outbreaks during the second wave, But if you look at the tail end of the figure on the right side, you'll notice we have started to see many more of those explosive outbreaks during the recent intensification of the second wave. This is another figure showing the second wave of COVID-19 in Ontario long-term care homes. If you look at the orange lines, those are active resident cases in the solid line, and the dashed line represents active staff cases. There's been well over 500 active resident and staff cases since the start of November 2020. And you'll see the resident deaths, the dashed line are the cumulative deaths. We're now at 543 deaths, and you'll see the really recent acceleration of these deaths, with again 80% of the 543 resident deaths occurring during the second wave, occurring between November 1st and December 12th, 2020. We know that the greatest risk factor for long-term care home outbreaks is the community incidence of COVID-19. These figures show the relationship and the association between COVID-19 incidence in the province and the community overall, and COVID-19 incidence within long-term care homes. The blue line represents the COVID-19 incidence within the community. The yellow lines represent the COVID-19 incidence within long-term care homes. You'll see, with the exception of the North region, which is more geographically dispersed in terms of long-term care homes and has not seen long-term care home outbreaks with the same phenomenon that we have seen in other parts of the province, there's a very close relationship. If you look at the entire province of Ontario on the top left figure, if you look at Toronto region in the bottom middle figure, you can see that the curves closely parallel each other with a lag of about 3 weeks between when community incidence rises and when you start to see long-term care home cases. And so, as we demonstrated in this study, when the daily active COVID-19 community cases are 2.3 per 100,000 individuals, there's a 75% chance of a long-term care home outbreak occurring 5 days later. Really emphasizing again that the strongest risk factor for whether a long-term care home is going to experience an outbreak is the community incidence of COVID-19. We know that virus is often being brought from the community into long-term care homes unknowingly by staff who live in the community and then work in long-term care homes. Recognizing this early on in the pandemic, the province of Ontario implemented a single site work order on April 21st, 2020, that ensured that employees of long-term care homes could only work in one healthcare setting, long-term care home, or congregate care setting for older adults, such as retirement homes, within a 14-day period. What we do know is that this order did not apply to temporary staff or other contract staff that are not employees of long-term care homes. We used anonymized mobility data to look at the impact of this public order on connections between long-term care homes in terms of staff who spent more than an hour within 2 long-term care homes within a 14-day period. You'll see on the left bottom figure, each dot there represents a long-term care home. And you'll see the lines that connect them. Those are those connections that I spoke about, where a home is connected, where an individual had a mobile device that checked into one of the long-term care homes, that spent an hour, at least an hour within that long-term care home, and spend at least another hour within another long-term care home within a 14-day period. You'll see in the 7 weeks before the order, from March 1st to April 21st, 2020, there were 266 homes in the province, or 43% of all homes that were connected. After the order on the bottom right, that dropped to 79 homes, or 13% of all homes, in the 7 weeks following the order. So the public order had the effect of reducing connectivity of homes by 70%, but we do know that there are individuals who are not covered by this order, and there continues to be some ongoing connections between homes that may be contributing to spread of virus. We looked at data during the first wave, examining the impact of for-profit status on COVID-19 outcomes in Ontario long-term care homes. This was a retrospective cohort study of all long-term care homes in the province from March 29th to May 20th, 2020, which really represented the bulk of cases within the first wave. We found that the outbreak risk, as anticipated, was associated with community incidence of COVID-19, but not for-profit status. And we showed that earlier in the brief in that close relationship between community incidence and long-term care incidence of COVID-19. But what we did find was compared with nonprofit homes, for-profit homes had larger, so nearly twice as many residents were infected with COVID-19 and deadlier COVID-19 outbreaks, with nearly 78% more resident deaths in these for-profit homes as compared to nonprofit homes. When you look at the data, we found that these associations with for-profit status were largely mediated by the older design standards, so for-profit homes having design standards that meet or fall below those established in the year 1972. So homes with older design standards tend to have more multi-occupancy rooms, smaller square footage, not only within the resident rooms, but also within common spaces. And they also had more chain ownership. And this is displayed in the figures below. On the bottom left, these are the proportion of residents that have confirmed SARS-CoV-2 infection. And what you do notice at the top are a lot of the darker triangles, and the darker homes are those that are older homes, and the triangles are chain ownership. So see that there are many for-profit homes that did well in terms of the bottom left being the proportion of residents with infection, and the bottom right being the proportion of residents who died from SARS-CoV-2. But you also notice there's a large clustering of those dark triangles at the top, and those dark triangles are more common in in the for-profit homes, meaning that for-profit homes have a larger proportion of homes that have older design standards and chain ownership, which probably explains the association somewhat that we demonstrated in the study. Another retrospective cohort study using that same data set of all long-term care homes from March 29th to May 20th, 2020, looked at the impact that crowding within a long-term care home had on incidence of COVID-19 infection and COVID-19 resident mortality. So developed a crowding index, which was the mean number of residents per room and bathroom. So if each resident had their own room and bathroom, you'd have a crowding index of 1. And we found that crowding was associated with increased incidence of infection, and mortality. And that is strongly displayed in the bottom right there in terms of the cases of COVID-19 in the blue and the deaths from SARS-CoV-2 infection in the orange. And there's a strong relationship between the crowding index, again, mean number of residents per room and bathroom per home, and both of those outcomes. What we did not see, expectedly, was that there was a relation. We did not find a relationship between crowding and the risk of a COVID-19 outbreak. Again, that's related to the community incidence of COVID-19. If you look at the bottom, this is displaying the size of the outbreak, and you'll see the number of outbreaks that involve more than 100 residents. The majority of those outbreaks in the orange, where the crowding index is greater than or equal to 2, the majority of the large outbreaks, with the exception of one, all happen within crowded homes, where you had more than 100 residents infected. And so with simulation, we showed that converting all 4-bedded rooms to 2-bedded rooms prior to the pandemic, we could have averted nearly 1,000 COVID-19 cases, or nearly 20% of cases, and 263 COVID-19 deaths, or nearly 1 in 5 deaths. But of course, this will require 5,070 new 2-bedded rooms in the long-term care sector that were not built before the pandemic. So to summarize the data I've displayed in terms of the anatomy of long-term care home outbreaks and spread, if you look at the left-hand side, COVID-19 starts with COVID-19 outbreaks in long-term care homes. The greatest risk factor is the incidence of COVID-19 within the community. And the staff live in the community. And we know that there are neighborhood factors associated with COVID-19 incidence: socioeconomic status, visible minority status, household crowding, and essential worker status. Outbreaks begin in long-term care homes when COVID-19 is imported from the community. And there are several things that contribute to that: undetected, asymptomatic, and pre-symptomatic staff, the absence of universal paid sick leave for workers who sometimes need to make decisions between coming to work sick or making an income. We know there's employment of part-time staff who work multiple jobs and may not be covered by that order that I showed earlier in terms of the mobility data, and still may work within multiple healthcare settings within a 14-day period, or may work in other front-facing jobs where they're at risk of COVID-19. And again, Temporary staff work in multiple healthcare settings, again, not covered by that order. Outbreaks then spread within homes, and we've shown some of the risk factors associated with spread. The older design standards where homes have design standards that meet or fall below those established in the year 1972, chain ownership, multi-occupant room and shared bathrooms, and crowding within the home. And this is exacerbated by staffing shortages, which are precarious even pre-pandemic, availability of personal protective equipment, something that's been largely solved within the sector, and insufficient infection prevention and control capacity within the long-term care sector. One of the things that we know happened to residents, and we've heard this from residents, from family members, from caregivers, and from long-term care staff, is that the conditions of the COVID-19 pandemic also caused harm to residents. Not just infection caused harm to residents. And one of the ways we looked at this was by examining rates of prescribing for psychotropic medications among long-term care home staff. The psychotropic medications we examined were antidepressants, trazodones, antipsychotics, and benzodiazepine. And these are medications that have been closely scrutinized within the sector because while they do have a role in certain clinical situations, they were generally felt to be overprescribed, and there were many quality improvement initiatives within the sector to try and promote more judicious prescribing of these medications because there are side effects with known harm, including antipsychotics in people with dementia, where there's increased risk of all-cause death. We'd also examined two medications, metformin and statins, on the bottom left and bottom right. Metformin is used to treat diabetes, and statins are used to treat high cholesterol. And these were medications we did not anticipate to change during the pandemic. What we did in this study was we examined the monthly proportion of residents who were prescribed one of these medications, and we looked well beyond the pandemic to establish what was the general secular trend of prescribing pre-pandemic. You'll notice the upward line where you start to see some of the graphs take off. That's the start of March 2020, the start of the COVID-19 pandemic within Ontario and the long-term care sector. We went back to well before the pandemic in a year prior into 2009 and documented these monthly prescribing rates to generate the trend that you see in the blue line. What we find is at the start of the pandemic, there is a sharp increase in prescribing of antidepressants, trazodone, antipsychotics, and benzodiazepines, which had been on a downward trend. You still see an increased prescribing, even though the overall rate continued to decline as it has on that trend. You'll notice from the y-axis that the absolute differences are small, within the range of 1 to 2%. But as mentioned, there are nearly 80,000, or there are more than 70,000 long-term care residents who live within the province's home. So these differences are quite substantial, even on an absolute level. You will see that for the medications we did not expect to change, metformin and statins, those actually went down at the start of the pandemic, either reflecting the fact that people taking those medications were more likely to die from COVID-19, or refilling medications for other chronic diseases weren't prescribed with the same intensity or re-prescribed with the same intensity as those psychoactive medications were. Some of the increased prescribing that was noted may have been used to treat palliative symptoms among residents who were dying, but we also know they were likely used to treat things like responsive behaviors among people living with dementia who were experiencing psychological distress as a result of being separated from family caregivers, living within conditions that were anxiety-provoking, and that's reflected in the increased prescribing that we did note. So how has the evidence thus far informed policy? Well, the provincial pandemic surveillance tools now incorporate the documented risk factors for long-term care outbreaks and deaths that we highlighted in this evidence brief. That includes looking at community incidence of COVID-19, incorporating homes with older design standards, or looking at homes with older design standards, those with chain ownership, and those that have high crowding indices. There was an emergency order, as mentioned, on April 21st, 2020, restricting long-term care staff from working in more than one long-term care home or healthcare setting within a 14-day period. But as we showed, that didn't apply to temporary agency staff or other contract staff, and there continues to be substantial residual connectivity between homes, with 13% of the province's homes still having a connection within a 14-day period, likely of workers who are working in multiple settings. We know that the directive number 3 was revised first to limit admissions and later to limit occupancy to no more than 2 long-term care residents per room in an attempt to reduce crowding within the province's long-term care homes, recognizing that a fifth of all cases and a fifth of all deaths may have been averted had residents been occupying rooms with no more than 2 residents. And finally, recognizing that the conditions of the pandemic have been difficult for residents and also for their families and caregivers, the long-term care visitor policy was revised in the province of Ontario in early September to allow each resident to designate 1 to 2 essential family caregivers who can visit without time limits, including when a home is in outbreak. So as mentioned, there are some outstanding issues, and we've highlighted some measures that could be effective in preventing further long-term care home outbreaks and deaths. The first issue is to promote staff entry and retention into the sector by improving the conditions of work. We know that there is significant attrition within the field, and there's also difficulty in enticing workers to the long-term care sector. There is a desire for more full-time opportunities with benefits for workers. And there's also a huge desire to reduce the burdens that workers are asked to take on in their day-to-day jobs by increasing the number of hours of care provided to each resident. Standards have been suggested and actually committed to by the government in terms of 4 hours of care per resident within long-term care homes. The second approach looks at something that I think is really necessary in terms of preventing long-term care worker infection, and that's community-tailored approaches. I spoke earlier that the chains of transmission begin in neighborhoods for COVID-19 and is later imported into long-term care homes unknowingly by long-term care workers. Community-tailored approaches would look specifically at moving away from a one-size-fits-all public health intervention approach and looking at tailoring the approach to the communities where long-term care workers reside. That would be by using language or using approaches that speak to them in their native tongue or language, by using culturally sensitive approaches. Those would be the bottom-up or grassroots approaches. There are also some top-down approaches that could be employed as well in terms of paid sick leave and eviction moratoriums within the province to support these workers who we know are overwhelmingly women, and 40% of the personal support workforce in the province of Ontario are visible minorities. And many of them do live in the communities that are COVID-19 hotspots. So a real community-tailored approach to bring testing to them, to work with the communities to tailor approaches, and by top-down approaches to support these workers during the pandemic with things like paid sick leave would have the benefit of preventing long-term care workers from being infected and ultimately importing cases into long-term care homes. Further decrowding homes by continued limits on occupancy, as mentioned, in terms of limiting the number of residents per room by having no more than 2 residents per long-term care room, and also because of the fact that people are already living in these homes and there's no space to move them, thinking about temporary housing like field hospitals might be something to consider during the pandemic to try and reduce crowding within homes so that if a case does get in, it doesn't spread as widely and lead to as many infections and deaths. Another measure would be detecting long-term care worker infection and preventing importation into long-term care homes by prioritizing workers for testing and turnaround time, things that are already being done to some extent, and also, as mentioned, by guaranteeing workers paid sick leave. There needs to be a continued enhancement of infection prevention and control within long-term care homes. There have been models that continue to be rolled out across the province in terms of a hub and spoke model, where there is a central hub with IPAC expertise or infection prevention and control expertise situated within acute care settings, and then the spoke in terms of the specialists that work in the community and can seek and collaborate with the hub. But there needs to be more IPAC capacity on the ground, And there have been suggestions to secure one specialist, one IPAC specialist per 200 beds in a long-term care home to really build capacity in terms of the IPAC health human resource. Really, I think pursuing a balanced and nuanced approach to public health measures and infection prevention in long-term care homes is necessary. The province has moved to make a visitor policy that now differentiates between the social or general visitors and the essential family caregivers, and giving access to essential family caregivers in the way they need to be able to participate as essential partners in care. That was an extraordinarily promising approach within the province. But there needs to be a more balanced approach in other ways. Residents are now no longer allowed to go on short-term absences from homes. And there's a difference between going on a short-term absence into the community, into an indoor setting, to congregate with many other individuals in high-risk transmission settings, or those that are simply looking to go for a walk around the block or for some fresh air, for which many residents are no longer able to do after the short-term absences were taken away. Similarly, many homes have now suspended things like congregate dining and social activities in homes that are situated in high-risk communities, those that are situated in the tiered provincial framework within the red or gray zones. And we've shown how residents need to have social stimulation just like the rest of us. They need to be able to congregate with others just like the rest of us within a safe way within the people within our own homes. And we need to find a way to have balance and nuance in terms of the public health measures to allow residents to maintain their health and well-being during the pandemic. We now know that the vaccine has arrived on Canadian soil for COVID-19, and this is a hugely just hopeful development within the entire pandemic, but also within the long-term care sector. We need to ensure that we secure advanced consent for vaccination from residents. As mentioned, 70% live with dementia, 90% have cognitive impairment. Many of them rely on substitute decision makers for informed consent for things like a COVID-19 vaccination. It's going to take time to secure consent for the more than 70,000 residents who live in the province of Ontario in long-term care homes. And we need to work on strategies, behavioral change strategies, to improve vaccine acceptance amongst long-term care home residents, their families, essential family caregivers, and the staff to try and maximize vaccine uptake. And finally, as evidenced by this brief, the availability of data on long-term care homes in the province has made a difference in real time to public health policy and to approaches to the long-term care sector in real time. And we need to work on continuing to optimize data on long-term care homes for the duration of the pandemic and beyond. So to circle back to the key messages, again, Ontario long-term care home residents have experienced disproportionately high morbidity and mortality, both from SARS-CoV-2 infection, but also from the conditions of the pandemic. We've shown that comparing waves 1 and 2, there are some improvements, but there's a really concerning intensification of the second wave, which started September 1st, 2020 within long-term care homes, with nearly 70% of cases and 80% of resident deaths occurring since November 1st, 2020. Without action, we will see a substantial and continue to see a substantial loss of life before we have widespread distribution of a vaccine. We've shown that the predictors of long-term care home outbreaks and spread of infections and death are well documented within the Ontario context, and they remain unchanged during the second wave. Some of the evidence that we have reported in this brief has been effectively leveraged to support public health interventions and policies, but there are a number of outstanding issues in the sector, and several measures were proposed which have the potential to save lives and to prevent more outbreaks within the long-term care sector. I want to thank you for your attention to viewing this science brief, on behalf of the COVID-19 Science Advisory Table, we thank you for your interest in this brief.